So this is a patient with a retinal detachment, and retinal tears is located temporarily. So I performed a peripheral and vitreous shaving and routinely, and then I compressed the sclera, and then using a 25 gauge at a 10 kb and bevel cutter, and I performed peripheral vitreous nicely, and then I performed the fluid gas exchange. And after the fluid gas exchange, I noticed and there was a small colloidal detachment, and I suspected and this colloidal detachment caused by expansive hemorrhages. So I stopped the for more surgery and put laser and finished up my surgery. The following day, and when I checked this patient, colloidal detachment got disappeared.
So it was not a choroidal hemorrhage. It didn't look.
Yeah, I think so.
So you got some buckling effect while doing the.
Yes, I expected doing something.
Temporary buckle. Well, any comments?
Yeah, the chorus commented, and in the same cases, and very good things. I do an adult procedure to do a peripheral vitrectomy. So a number of procedures caused and possibly causing choroidal hemorrhages or choroidal detachment. We and avoid too much procedure.
So one of the things. So I do very similar to do on my retinal detachments. I do peripheral vitreous shaving, and a few things I learned over the years was I lowered the pressure a little bit. I used valve trocars, and most importantly, when I do not let go with the depression. So when you're depressing, you do vitreous shaving, you always very gently let go and not let go and come back and let go, because that fluctuation of the pressure is what I think makes the eye more sensitive later on, either to get hyphema or a choroidal detachment. The other important point is that when you put perfluorine in, the same thing. If you do laser treatment with this depression, you want to let go slowly. If you let go too quickly, I think it can induce a vacuum effect and get the perfluorine under the retina and increase the likelihood of you getting submacular perfluorine. But that is one of those techniques that I think you want to do more gently and may prevent you from getting choroidal detachment. 2 points. One is, first go with the cutter, then depress. Don't depress first and then go with the cutter, because what ends up happening is sometimes, especially if you're nasally, you tilt the eye without noticing, and then you go with the cutter in, and if the patient is phakic, your cutter ends up in the lens. So you go with the cutter, and as David pointed out, you start cutting so the eye gets a little bit softer, then you start depressing to get the plane, and again, avoid the fluctuations during depression.